I am Mitsuharu Ueda, and I am a professor of Department of Neurology, Kumamoto University, and the director of Amyloidosis Center at Kumamoto University Hospital, Kumamoto, Japan. I graduated Kumamoto University, Japan in 1999. I completed my residencies in the Department of Neurology at Kumamoto University Hospital, Kumamoto, Japan. I spent 1 year at Arao City Hospital near Kumamoto City, where there is a concentration of ATTR-V Balsartan patients. So I studied amyloidosis research and I earned my PhD at Kumamoto University. I was a visiting research fellow in the Department of Pathology and Laboratory Medicine at Indiana University before returning as associate professor. I became professor of neurology at Kumamoto University and director of Amyloidosis Center at Kumamoto University Hospital in 2020. My research interest includes the pathogenesis of ATTR amyloidosis and animal and cell models for amyloidosis and molecular diagnosis of genetic disorders. To facilitate early diagnosis and early treatments of amyloidosis in Japan, we established an amyloidosis center in 2012 to provide a consultation service for amyloidosis and to increase awareness of amyloidosis. As treatments for specific types of amyloidosis have advanced, the importance of early diagnosis and early treatments have increased. However, there were only a limited number of facilities specializing in the early diagnosis of amyloidosis within Japan. The Amyloidosis Center was established at Kumamoto University with the goal of improving early diagnosis and early treatments of amyloidosis nationwide. I believe obtaining research grants was necessary for the establishment of the center. Previously, ATTR-V amyloidosis patients were found in the limited two areas, Kumamoto and Nagano, Japan, and thought to be a rare neurological disease in Japan. But because diagnostic method and awareness of amyloidosis have been improved, now estimated number of patients increased to 500 to 1,000 in Japan. To date, more than 50 kinds of TTR mutations were found in Japan. In Japan, 80% of ATTR-V patients have TTR Balsartan mutation, and the other 20% of patients have non-Balsartan TTR mutations. Most of non-Balsartan patients are from non-endemic areas in Japan. This data shows the progression of treatments for ATTR-V amyloidosis over time in Kumamoto University, divided by age at onset, under 50 and over 50 years old. Initially, most patients received no treatment. In the 1990s, liver transplantation became common in early onset patients. By 2011, disease-modifying drugs became the main treatment for ATTR-V amyloidosis patients. This slide shows the trends in the number of cases for the amyloidosis diagnosis support service. As you can see, the number of cases have been increasing year by year. This slide illustrates the results of amyloid typing with immunostaining at Kumamoto University. The distribution of amyloid type is 60% ATTR wild type, 2% ATTR-V, and 30% AL amyloidosis. Recently, the number of cases analyzed for ATTR wild-type amyloidosis has increased. This increase is likely due to enhanced disease awareness alongside developments in disease-modifying therapies for amyloidosis.
One of the most important operation of Kumamoto University Amyloidosis Center is to support the physician and the staff of other institutes in diagnosing amyloidosis patients, because we have the diagnostic core and we can provide the physicians and the staffs of other institutes with immunohistochemistry and also proteomic analysis. Additionally, we have the specialists of each amyloidosis. For instance, Dr. Ueda is the big guy of the ATTRV amyloidosis, and I'm responsible for the AL amyloidosis therapeutic core of this institute. And we also have a staff of ATTR wild type amyloidosis. So as a day-to-day operation, we are capable of providing the correct diagnosis, and also we can support the patients or the staff of other institutes by suggesting the best therapeutic options.
This slide shows the clinical features of the three main types of systemic amyloidosis: ATTR-B, ATTR-Y type, and AL. Cardiac symptoms are commonly found across all types. Neuropathy is frequently seen in ATTR-B. Carpal tunnel syndrome occurs in all types. Autonomic dysfunction is observed in both ATTR-B and AL. Kidney and liver involvement is primarily seen in AL amyloidosis. Gastrointestinal symptoms are often severe in ATTR-B, with occasional eye symptoms as well. This slide illustrates the diagnostic process of amyloidosis. First, amyloidosis must be suspected based on clinical findings. Next, to confirm amyloid deposit, imaging and/or biopsy is required. Finally, amyloidosis typing is necessary, as specific treatments differ significantly depending on the type of amyloidosis. In Kumamoto University, we performed amyloid typing using a hybrid system that combines immunohistochemistry and mass analysis. We diagnosed ATTR-B amyloidosis based on the following three findings: clinical symptoms and signs, TTR gene mutation, and tissue amyloid deposits. In any case, suspecting amyloidosis is the most important step for the diagnosis of amyloidosis. ATTR-B amyloidosis patients develop various kinds of symptoms such as polyneuropathy, autonomic dysfunctions, carpal tunnel syndrome, CNS, renal, cardiac, and ocular symptoms. This slide shows initial symptoms of ATTR-B amyloidosis patients. Typically, they show distal dominant pain and less of cold sensation, especially in lower limbs. They also show distal motor weakness, dysautonomia, and cardiac and ocular symptoms. There are two diagnostic pathways. One is biopsy first pathway, and the other one is a TTR gene test first pathway. In biopsy first pathway, when you suspect amyloidosis, you need to do biopsy. If you find ATTR amyloid deposit in biopsied samples, in the next step, you should do TTR gene test to differentiate ATTR-B and ATTR-Y type amyloidosis. On the other hand, in a TTR gene test first pathway, when you suspect ATTR-B amyloidosis, you do TTR gene test. If you find pathogenic TTR variants, you should do biopsy and imaging. We usually do a biopsy first pathway. TTR gene test pathway is quick and easy, but please note that you can not exclude ATTR wild type and AL amyloidosis. The treatment methods differ depending on the subtype of amyloidosis. For hereditary ATTR amyloidosis, treatments include TTR gene silencing therapy with siRNA drugs and TTR tetramer stabilizer. For wild-type ATTR amyloidosis, TTR tetramer stabilizer is used. And for AL amyloidosis, chemotherapy is administered. Additionally, appropriate symptomatic treatment for various symptoms is also important. The care for amyloidosis patients who visited our hospital is managed by various departments. Hereditary ATTR amyloidosis is primarily handled by the Department of Neurology, wild-type ATTR amyloidosis by the Department of Cardiology, and AL amyloidosis by the Department of Hematology.
Our center has hematologists, as myself, and cardiologists and nephrologists who are involved in amyloidosis therapy. For example, we hematologists are responsible for treating AL amyloidosis patients, but I ask the cardiologists and nephrologists to get involved in treating a certain AL amyloidosis patients because AL amyloidosis patients usually suffer from cardiac failure or nephrotic syndrome. So it is very important to take care of a certain patient as a team, including hematologists, cardiologists, and nephrologists. And I always asked the other staff to please keep on taking care of this patient. And we use email or a direct phone call to communicate with each other and to keep on taking care of this certain patient.
We are conducting various clinical studies for ATT, hereditary type of ATTR amyloidosis and wild type amyloidosis, also AL amyloidosis, in collaboration with pharmaceutical companies. And we also do basic research studies for amyloidosis using cell culture model and animal models to develop new therapeutic drug. We published our research findings for ATTR-B, ATTR-Y type, and AL in international academic journals and participate in the International Society of Amyloidosis. We are looking to offer amyloidosis diagnostic support to other Asian countries. We are now planning to build an English language website to provide amyloid typing service. Additionally, we are reviewing appropriate method in compliance with relevant laws and regulations for exchanging clinical samples and clinical information. A major challenge lies in securing a long-term funding and training the next generation of experts of amyloidosis. First, it is essential to establish a system for conducting appropriate amyloid typing. I believe immunohistochemistry using antibodies specific to amyloid typing is the most suitable method in each hospital. Furthermore, if you can establish a system to perform TTR genetic testing and mass spectrometry, you would be able to develop an amyloidosis diagnosis support center. Securing ongoing funding will always be a challenge.